The oculomotor nerve, the trochlear nerve and the abducens nerve transmit motor information to the extraocular muscles that control eye movement and eyelid function. Cranial nerve 3 in particular innervates most of the extraocular muscles, the superior rectus, the inferior rectus, the medial rectus, the inferior oblique, as well as the levator palpebrae superioris. The third cranial nerve also has parasympathetic fibers which project to the ciliary ganglion for pupillary constriction. The fourth cranial nerve, the trochlear nerve, innervates the superior oblique, and the sixth cranial nerve, the abducens nerve, innervates the lateral rectus, and we use the mnemonic LR6SO4 to help remember this. You should be aware of the various actions of the extraocular muscles. The superior rectus is involved in eyeball elevation, adduction and medial rotation of the eyeball. The inferior rectus is involved in eyeball depression, adduction and lateral rotation. The medial rectus is involved in adduction of the eyeball, and the lateral rectus is involved in abduction of the eyeball. The inferior oblique elevates, abducts and laterally rotates the eyeball, and the superior oblique is involved in depressing, abducting and medially rotating the eyeball. So on inspection, observe very carefully for ptosis, and in this patient you can see right-sided ptosis. This may occur due to oculomotor nerve palsy, which affects the levator palpebrae superioris, or as a result of Horner syndrome, or neuromuscular pathology such as myasthenia gravis. Examine the movement of the eyeball by holding a pin approximately 30 centimeters in front of the patient's eyes. Ask them to focus and follow the object by keeping their head still, and ask them whether they experience any diplopia or pain when they follow the object. And you should perform a H movement as well as the direct vertical and up and down movement. Observe for any signs of nystagmus. Oculomotor nerve palsy presents in a very specific way. So this represents a third oculomotor nerve palsy. Remember that the oculomotor nerve supplies the extraocular muscles except the superior oblique and the lateral rectus, and as a result of that, if the superior oblique and lateral rectus muscles are working unopposed, then the pupil will be in a down and out position. Moreover, there is ptosis because the oculomotor nerve innervates the levator palpebrae superioris, and look out for mydriasis. If you have a loss of the parasympathetic function of the third cranial nerve, the unopposed activity will lead to mydriasis. So in this patient, you would describe that the patient has asymmetric eyes in the neutral position. There's lateral and downward deviation of the left eye. There is left-sided ptosis due to the denervation of the lateral palpebrae superioris, and whenever the patient moves their eyes, there are disconjugate eye movements leading to diplopia in all directions of gaze except when looking in the direction of the affected eye. The pupil itself needs to be carefully examined for whether or not the pupil is normal, dilated or constricting. If the pupil is affected, then that's known as a surgical palsy, and if the pupil is spared, then that's commonly known as a medical pupil, and we'll explain that in a moment. With an oculomotor nerve palsy, acuity and visual fields would be expected to be normal. So the pupil must be examined carefully. Pupil involvement in the third nerve palsy. Be aware of the transsectional anatomy of the third cranial nerve. You can see in this diagram the peripheral fibers, demonstrated as purple squares, control the pupillary constriction. They're the parasympathetic fibers which are arranged peripherally. The central fibers are the motor fibers which innervate movement of the eyeball. Consequently, anything that extrinsically or externally compresses the third nerve will affect the pupil and will impair the constrictor mechanisms. And we consider surgical causes such as aneurysms, space-occupying lesions or tumours. But if only the vasa novorum, the central fibers, are affected, e.g. due to diabetes or hypertension, the peripheral fibers are spared, then the motor control of the eye is lost, but the pupil is still able to constrict. The causes of third nerve palsy include diabetes and hypertension, aneurysms, multiple sclerosis, and trauma. And to therefore investigate the cause of a palsy, patients should be checked for diabetes through HbA1c, monitor their blood pressure, but they should also undergo neuroimaging, including an MRI and an MRA, to exclude ischemic or aneurysmal or space-occupying lesions damaging the nerve. The trochlear nerve, or the fourth cranial nerve, as we mentioned, innervates the superior oblique muscles, and if the trochlear nerve is damaged in isolation, that would result in vertical and torsional diplopia due to loss of the superior oblique's action of pulling the eye downwards. Patients try to compensate for this by tilting their head forward, trying to minimize vertical diplopia. And the sixth cranial nerve, the abducens nerve, innervates the lateral rectus, which is involved in abduction of the eye. Abducens nerve palsy, therefore, results in unopposed adduction of the eye by the medial rectus muscle, resulting in a convergent squint. Patients present with horizontal diplopia, which is worse when they attempt to look towards the affected side, and the patient's left eye is deviated medially due to the unopposed action of the medial rectus, which is innervated by the third cranial nerve. So on examination, the patient will have disassociated conjugate eye movements leading to diplopia in all directions of gaze except when looking away from the affected side. The etiology of the six cranial nerves includes diabetes, hypertension, but because of its long tortuous route, raised intracranial pressure can also damage this nerve, as well as an acoustic neuroma. So to determine the cause of a sixth nerve palsy, it's pertinent to examine the patient's hearing to determine whether or not there's a likelihood of an acoustic neuroma, refer for formal audiometry, as well as testing the patient for their blood sugar, signs of blood pressure, and organising neuroimaging, including an MRI of the brain. So in summary, as a checklist for these nerves, ensure that the eyes are inspected, including the eyelids for ptosis, and examine eye movements. Thank you for attending this medicine masterclass.